Good morning, everyone. And let me start by apologizing to speak in English. But I'm afraid it would take much longer than 30 minutes if I tried to speak in Spanish. So I'll just wait for my slides to come up. First of all, thank Lola for the kind introduction. And I'll also like to thank ATAM, Viva Libre, and Neuroalianza for the invitation to be here today, and all of you for your presence and your attention. So I hope I will not be too technical and detailed in trying to bring to you today some of the advances in a particular area of neuroscience and neuropsychiatry, which is non-invasive brain stimulation, and how I believe it is currently already a novel and very interesting clinical technique for use in neuropsychiatry, and my vision about a couple of ways in how it can contribute in the future for additional advances, both clinically and research-wise. So, brain stimulation has a long history in neuropsychiatry and in psychiatry since the first half of the last century. The use of electricity to induce generalized convulsions was a well-known and very much used approach to treat certain psychiatric conditions. And while this image of that can very easily transmit brutality and insufficient respect for individual rights is a clear image, and that was something that happened. Electroconvulsive therapy is still very much used, it's still very much useful, and currently it's done in a much more controlled and respectful fashion. And we do it in Portugal. I'm sure it's done also here in Spain, in the UK, surely also. And it is very, very much a life-saving intervention in some psychiatric and neuropsychiatric conditions. Of course, the stigma of electroconvulsive therapy, the fact that it has to be done under general anesthesia, and the risks that are involved, both in terms of what happens to you when you are anesthetized, and also in terms of the brain, the memory impact of doing electroconvulsive therapy, has led to a significant amount of research into how the same effect could be obtained with a less, let's say, invasive and a less stigmatized intervention. The techniques that have come up in an attempt to modify electroconvulsive therapy, to modify the ways in which we can directly stimulate the brain and through that obtain some therapeutic advantage, are diverse. Here I'm bringing two of the most successful ones: transcranial direct current stimulation, which is essentially very similar to electroconvulsive therapy, but with much lower intensity of stimulation and no objective of actually inducing a convulsion, and a slightly more complex technique is transcranial magnetic stimulation, of which I will speak in more detail over the course of my lecture today. So, this is essentially the conceptual underpinning of what transcranial magnetic stimulation is. So what happens is that when you have a coil through which you're passing current, and you do this with particular temporal characteristics of your electrical stimulation, this coil is going to produce a magnetic field. So a field that can be conducted in the absence of a particular material element, like an electrode that would have to be implanted in the brain, so you don't need an electrode. And the existence of this magnetic field, when touching conductive tissues that are underlying the field, will lead to the production of a new electric current that can then create a bunch of different effects, including, for example, the activation of a light bulb. So you can transmit energy from one source to another without direct contact between the two. And that's the essence of the non-invasive characteristics of transcranial magnetic stimulation. So trying to convert this in a more graphic way to how it's done in humans, if you have a coil, as I'm showing here, that's where we're producing the electric current, and this coil is placed over the scalp. So this is a healthy scalp, no lesions, no cutting, nothing. This will then produce a magnetic field that I'm picturing here in blue, and this magnetic field is going to induce an electric field in the underlying tissues. And the most conductive tissues, one of the most conductive tissues that are beneath the scalp is the brain. And so the brain is going to be one of the areas where this electric current is going to be created and where it's going to have a particular impact. So this is an actual photograph of a TMS device. And obviously, one of the important elements in terms of what TMS can do to your brain is which area of the brain you're going to put your coil on. So in this particular example, where TMS is being placed over the more occipital areas of the brain, what is expected is that the individual will see light flashes when we stimulate with the coil the underlying nervous tissue. Another interesting component of TMS is that depending on the frequency with which it's done, it can do different things to the brain that's underlying. So I'm going to have a video here. Oh, we need to go back. Sorry. So this video is going to show you an image of the cat cortex with a low-frequency stimulation. So you see that this has inhibited activity in this cortex. It's now blue. When this is done with a higher frequency, this is now 10 hertz, 10 stimulations per second, you're seeing that the brain, the cortical tissue, is becoming red. So it's becoming activated. There's more activity rather than less activity occurring in that cortical tissue underlying the TMS stimulation. And so this has been shown over and over again, that in fact, when you have a low-frequency stimulation, you're going to reduce activity in the underlying cortex. When you have a high-frequency stimulation, you're going to enhance, increase activity in the underlying cortex. And due to this evidence, high-frequency stimulation of frontal cortical areas in the left-hand side of the brain has been tested and approved as a treatment modality for resistant depression. So for individuals that are depressed but do not respond to classical treatments such as antidepressant drugs. So this is data from the trial that was used by Neuronetics, a company that produced the NeuroStar TMS system, to approve it by the FDA in 2008 for use in depression. In the United States, it's now a relatively successful endeavor. There are many hundreds of TMS sites across the country. And in fact, there is also evidence in terms of looking at the brains of individuals treated with TMS that the stimulation is doing what one would expect. So this is an activity assay using a nuclear medicine setup to look at the brain of an individual before having TMS with a 34 score in a depression severity scale. Thank you. And the same individual, after being treated with TMS over a number of sessions, now has a much lower score, so he or she is no longer depressed, and we're looking at increased levels of activity across several areas of the brain in this individual after treatment. So, as I was saying, this has become a very successful treatment. In the United States, it's used in hundreds of centers across the country. And it has become so successful that there are multiple companies now producing similar equipments for use in the same situations. This is the original TMS system. This is an Israeli system that was approved a few years later. And I have also contributed in a paper that's going to be published next week towards validating another equipment, the MagStim, a European company that has also produced a TMS stimulator for use in the same conditions. So this is, I believe, to some degree novel in that TMS was approved for depression in 2008, but it's no longer an example of innovation, right? It's now current use. It might not be current use in Portugal. I don't believe it's current use in Spain. I hope it will be sometime in the future, but it's not exactly innovative. But TMS presents multiple opportunities, I believe, for innovation in neuroscience and for innovation in neuropsychiatry. And one very interesting application of TMS is as a probe to measure excitability and plasticity of the brain. So we don't have very many techniques that will allow us to directly measure plasticity in the human brain in a non-invasive manner. But TMS provides this possibility in a way that I will explain now. So if you are measuring activity in muscles in the periphery, and you are delivering stimulations in the motor cortex that controls that area of the body, you're going to be able to measure the direct activity of your brain pulse in terms of the amplitude of your electromyogram in the periphery. So I hope you acknowledge my effort to bring a slide in Spanish here. So you will apply the magnetic stimulation. You will measure. So this picture we're measuring in the leg. Here we would be measuring in the hand, as is more classical. And if you apply that stimulation over the motor cortex, you will then induce a motor response that can be measured in the electromyogram and can be quantified according to the amplitude of this EMG. What is also very interesting that can be done is that you can perform these measurements before and after doing a high or a low frequency stimulation of that same motor cortex, and thus understanding the plasticity that was induced by your high or low frequency treatment. So for example, you would measure your EMG. So here's the setup with EMG in the hand. Measure your EMG, that is a measure of excitability prior to doing anything to the motor cortex. Then you can do the high-frequency stimulation of the same area and repeat your measure of excitability after. And what can happen is that you can have inhibition, so a reduction of the amplitude of the EMG, or you can have facilitation, an increase, measured as an increase in the amplitude of the EMG signal. And we did exactly this to try to predict if the effect of high-frequency transcranial magnetic stimulation to the cortex of individuals that were going to be treated for depression. So to try to measure if that effect done to with stimulation done to the motor cortex could predict the clinical response to TMS delivered to the frontal cortex. So it's indirect evidence, but what it would suggest, if this is true, is that the amount of plasticity that we're able to induce in a particular individual is predictive of the clinical effect of that same treatment applied to a different area of the brain. So this is how we did it. We measured motor evoked potentials, and this would be the EMG signal, and you can measure the amplitude. You then do a repetitive TMS protocol to the motor cortex, not to the frontal cortex. Repeat your motor evoked potentials and verify if there was facilitation, inhibition, or if nothing actually happened. After that, the individual is treated with a repetitive TMS to the prefrontal cortex, and after the treatment, we measure the clinical effect in terms of reduction of depression severity. So these are just some measurements in terms of the antidepressant effect of the treatment, measured both with the Hamilton scale and the Beck Depression Inventory, and essentially this is our outcome, the % reduction of the depression score, and we were exploring the different factors, different demographic and clinical factors that could predict the effect of treatment. There's nothing particularly exciting here, so age is not a good predictor in this cohort, gender is not a good predictor of antidepressant response, and baseline depression severity is a predictor but not particularly impressive. However, when we look at our measure of plasticity, so when we look at how much the motor cortex stimulation modified the excitability of the motor cortex, we now have a very robust predictive ability of this biomarker in terms of the antidepressant response. And this is true both for the Hamilton Depression Score, the Beck Depression Inventory, and as you can see here, now I never managed to refrain from some of these technicalities. This data doesn't look to be very normally distributed, so we did a non-parametric analysis that was pretty robust in demonstrating this clear effect in terms of prediction of antidepressant potential of the rTMS treatment. So it is very clear to us that these results demonstrate that modulation of corticospinal excitability by repetitive TMS to the motor cortex is predictive of the antidepressant response to rTMS delivered to the prefrontal cortex. And this raises, I believe, many questions in terms of the neurobiology of depression, the neurobiology of rTMS, and of potential clinical applications of these measurements in the future. In fact, we believe that measures of cortical excitability and excitability modulation by rTMS could be used in the future for individual adjustment of rTMS parameters. And if we want to be a little bit more excited about this data, it's even possible that this could be a good marker for clinical response to other treatments. Let's say, it's never been tested, but let's say this could be a good marker of antidepressant response to psychotherapy, to SSRIs. Let's see, I'm not sure, but let's see. And of course, this suggests that the modification of cortical excitability is the mechanism that's underlying the antidepressant effect of rTMS. And so, can modulation of cortical excitability be harnessed in other conditions beyond depression? And one condition where plasticity change is clearly altered is dementia, and specifically Alzheimer's disease dementia. And given that I believe I'm speaking to a crowd that is particularly interested in these conditions, I decided to bring some unpublished data that I have collaborated with Álvaro Pascual-León and others at Harvard, and that is submitted and I hope will be soon published. So this data, one of the experiments we performed here that is not particularly novel, but that was nice to reproduce, is to demonstrate that when we do that same thing I explained previously, so repetitive TMS to the motor cortex, and then see how this changes the excitability of the neurons in the motor cortex through the electromyogram, we see that there's the expected increase in excitability in healthy controls. HC is healthy controls. But you see much less modulation of the excitability, so presumably much less plasticity when we do the same intervention in individuals suffering from early Alzheimer's disease. So I'm sure everyone in the audience knows how difficult it is to treat Alzheimer's disease. There's very little to do. Most of our interventions are interventions designed to reduce the speed of progression of the disorder, and essentially there's very little therapeutic intervention in the classical medical perspective of what you can do for a patient with Alzheimer's disease. One element that has been to some degree disappointing is the effect of cognitive interventions. So actually getting individuals with early Alzheimer's to do cognitive training and verifying the effect of cognitive training in the progression of the disorder. This has not rendered consistent results and is, I believe, a treatment modality that needs additional evidence in order to be able to be used consistently. The use of non-invasive brain stimulation, either TDCS or TMS, has also been tested, mostly with single sessions and single brain areas. And the evidence that it has some effect in terms of cognition, long-lasting effect in terms of cognition in dementia and Alzheimer's disease, is also not particularly exciting. So what we decided to do here was, well, neuroplasticity, Lola just mentioned that, right? So changes in the brain are relevant for most things we do therapeutically in psychiatry, in neurology, in psychology, right? So there are changes in the brain with psychotherapy. There are changes in the brain with drugs. There's definitely changes in the brain with rehabilitation. So if we're talking about a brain, like the brain of someone with Alzheimer's disease, that is less amenable to change, less amenable to plasticity, and if we need plasticity for the effects of cognitive stimulation and cognitive training, what if we get both of them together? What if we stimulate the brain with TMS and at the same time provide some of the rehabilitation and cognitive training that is being tested in other instances? And our hypothesis was that we would see synergistic effects, that the effect of delivering TMS and cognitive training together would be greater and multiplicative in comparison to either of these two stimulations, to either of these two interventions separately. So this is the design of the study. The study was sponsored by a company that is developing the equipment to do this. So there's 6 weeks. The treatment lasts for 6 weeks. For these 6 weeks, there's daily interleaved cognitive training and RTMS in 6 brain areas. And so the stimulation and the cognitive training is done in coordination for a particular known function of a particular brain area. These are the targeted brain areas. These are some examples of the cognitive training tasks used for each of the different areas. And this is the design of the RCT. So you have a group of individuals that will do real brain stimulation and real cognitive training. there's a group of individuals that will do sham RTMS. So sham means that this is an attempt to do placebo brain stimulation, let's say, and that will do sham cognitive training. So this is our control group. And then a group doing sham brain stimulation, but real cognitive training. So doing only the cognitive training and doing a false version of the brain stimulation. And these are our results. And I believe these results are very exciting in terms of what can be done in a very frequent brain condition for which we have very little to offer. So what we're seeing here is a comparison of the change in this scale. This is a scale to measure symptoms of Alzheimer's disease in the three groups. So the group that was our full control group, the group that received real TMS and real cognitive training, and the group that received only cognitive training. And what you see is that cognitive training per se was clearly not a very impressive intervention in terms of what it's doing to the cognitive abilities of these individuals. However, when TMS is put into the equation, when brain stimulation is added to cognitive stimulation, we now see a just over 20% reduction in the severity of cognitive dysfunction measured in this small cohort of individuals. And when we look at the Clinician Global Impression Score, which was done in a blinded fashion relative to who was receiving what, the results are very much overlapping. The most impressive effect is resulting from real brain stimulation and real cognitive stimulation. What was also very interesting is that in these same individuals, we were doing measures of plasticity. So the same measures I talked about, stimulating the motor cortex, looking at what this does to the amplitude of the EMG signal. And we were doing this prior to stimulation and after the treatment. What was very interesting to verify, if you concentrate on this lower right-hand panel, left-hand panel for you, is that the changes in plasticity measured through ITBS, which is a different technique, were very much correlated to the changes in the scores in the ADAS-Cog, so in the severity of the Alzheimer's disease. So this is suggesting that, in fact, our ability to enhance improvement in these individuals is somehow related to our ability to modify the enhancement of plasticity in the brains of the same individuals. So just very shortly, the conclusions of this particular study, there's an increase in the ADAS-Cog. There's an increase in the ADAS-Cog, and this increase seems to continue for 1 month after the treatment, the brain stimulation has been interrupted. So there's a suggestion, an indication of a continuing process even after the brain stimulation has been interrupted. And also the fact that in our hands, the cognitive training in its own did not lead to significant improvements, suggesting that, as we had hypothesized, the combination with an intervention for brain stimulation could be critical to harness the benefits from a cognitive stimulation program. So before I end, I just wanted to acknowledge everyone that worked on the projects that I showed here. Most of the people I'm acknowledging here are at Harvard and the Beth Israel Deaconess Medical Center. Álvaro Pascual Leon, who's a neurologist, and Daniel Press, also a neurologist, are the lead clinicians for these projects that were conducted in Boston, and I collaborated with many of these other postdocs and technicians and graduate students in producing this data, and thank you very much for your attention.